Hi everyone, I'm Bobby Jo Jackson. This is my quality improvement project for my BSN at the State University of Buffalo, New York. Leadership at the bedside has many opportunities to see aspects of care that can be improved for patients and staff. A leader will look for ways to improve care and inspire colleagues to work toward positive outcomes. COPD is the third leading cause of death. It affects 16 million Americans are affected by this. Every time a COPD patient is readmitted with acute exacerbations, their lung function and quality of life is diminished. So decreasing these exacerbations is super important. Educating with interventions and smoking cessation. Decreasing exposure to air pollution, increase activity tolerance, medication regimens, attending pulmonary rehab, and pneumonia vaccinations. Off to the left is an algorithm that I put together that some of the colleagues had requested similar to a checklist or a focus sheet. It's COPD nursing admission, care plan, COPD orders, and discharge plan of care. The collaborators on this unit on 7C were Stacy Brockway, Sarah, Jody, and Alex. Together we did a cause and effect diagram to look for causes of readmissions of COPD. This helped us focus on our PDSA cycles. So this is a nurse-led education program, quality improvement project, to reduce COPD readmissions at the Buffalo VA by 10%, from 61 to 51 within 6 months. This will ensure every COPD veteran receives education to increase management of their disease process. We kept track of each part of the education that they received. The process measures are the pathophysiology, medication, activity tolerance, non-pharmacological interventions, infection prevention, and coping skills. Our balancing measures were nurse and patient satisfaction of the COPD education. The method used during the study was the IHI Quality Improvement Practicum with PDSA cycles. This study was based on the collaborative care model with patient-centered approach. This will lead to a comprehensive nurse-led education program. One of the studies that revealed a decrease in COPD readmissions by 55% was a nurse-led education. What they used for education was action plan, discharge planning guide, and multidisciplinary approach. Another study decreased their readmissions by 310, and this was just implementing pathophysiology. Baker found in her study decrease in dyspnea. They used an assessment scale similar to pain assessment, 0 to 10 scale, so it was easy to use for patients and staff. They were familiar with it. It's just 3 simple questions to find out their breathing pattern and recognize if they recognize when they're short of breath and what they do for their shortness of breath. Some of the non-pharmacological interventions were spirometry use, acapello, respiratory muscle strengthening. This helps, the acapello helps expel mucus that usually gets trapped with COPD patients. They have a difficult time expectorating. Infection prevention. This article showed a decrease with the pneumonia vaccination. What they did was they studied patients that had pneumonia and found the same strain that would have been covered by this vaccination. That would have decreased their infection. Coping skills. Coping skills such as breathing exercises, relaxation breaks, and activity management. In this study, Fayot and Baker had a nurse-led self-management education program on these aspects, on these interventions. There were less ER visits and less difficulty breathing, and a decrease in anxiety for the COPD patient. Our PDSA cycles. Our team first hypothesized, what do patients know about their education? We focused on the medication and how are we going to incorporate interventions. We used a teach-back method. So we did that with proper technique and a spacer administering MDI inhalers. We also incorporated pursed lip breathing. The nurses and the patients liked this quick and easy teach back method to see if they understood how to use their MDI inhalers and pursed lip breathing. So we stayed with the nurse teach back method throughout each education. We studied the effects of medication in education, which led us to give them a handout that had an illustrated picture of someone using the MDI. This also helped with the teach back method and using MDI and spacers. Now with each of our education that we do give COPD patients, we use our teach back method. This is from our PDSA cycles. We also use spacers. We used to have a hard time getting spacers. We didn't know where they came from. Sarah is actually getting them, some of them, on our regular ward stock. Another one that we implemented was activity intolerance. We taught simple techniques to increase activity intolerance by scheduling tasks, breaking up large tasks, and rest periods. We did this for morning cares. So doing their morning cares, then taking a break, then taking a walk, whether it be 10 steps or down the unit corridor. We studied the best activities that would increase or decrease their exacerbations. Patients were able to teach during the teach back, give examples of how they can increase their activity by taking breaks. As the QI evolved, so and you'll see on our run chart, the increase of knowledge of nurses, it was increased with the patients. So this is our run chart right here. We have 2 astronomical marks. That's with patient 8 and 11. That was the result of difficulty concentrating with the education, the interventions that were being taught. So what we did was we taught them breathing techniques and pursed lips. We had 1 trend in the beginning of the study and 1 run. The run may have been related to the in-service that we received from Courtney, the respiratory therapist manager. She brought to our unit how to use spacers in our MDI. Also, we talked to her about acapella use and incentive spirometry use. Nursing, inquiring, and inspiring. Admissions. They wanted a similar checklist of things that we would incorporate for our COPD patients. Also, they requested a discharge plan of education bundle for effective discharge. They they expressed hoping to have a nurse-led book for the patients so that they can take that home and refer back to for their families or themselves during exacerbations, just techniques for activities and so on and so forth, and giving educational resources, when to call the doctor. Implementing and spreading this change. Inspiring like-minded colleagues will continue the spread of information. Simplifying this QI project. Also using the IHI website to guide and spread the change. Share the information in our break rooms, and I also shared this information during our unit-based council committee. That's when I got a lot of feedback from colleagues on some things that they'd like to see to support their daily tasks in caring for COPD patients. The impact on practice. This quality improvement will benefit the facility by decreasing readmissions and misuse or different uses for our resources, increase patient and nurse satisfaction, and maintaining compliance of patient-centered care. The benefit to incorporating the COPD nurse-led disease-specific education program will increase veterans, their families, and their healthcare providers' knowledge of interventions for disease management to increase veterans' quality of life. The last page is the reference page. There are more references. These are the ones that I just used for my slide. If there's any questions, feel free to contact me on 7C. Thank you for your support.